Renew education and bringing to you again another case study that's worth looking at. They're all worth looking at. There's always something to learn from a case. This is a case where we're just looking at the lower arch right now. Look for the same case number for the upper arch because they obviously go together. And this is a fairly typical scenario where somebody has come in with implants or looking for more implants, in fact, but trying to figure out what to do with their teeth. They have a lot of dentistry done, and they just recently had a whole bunch of teeth extracted here, an infected tooth up here and stuff. So let's look at this bottom left side and kind of give the patient some idea of what to do. So I call this video not a graft, and I'll explain why. So let's look at our risk assessment here. We have pretty much light greens across the board. The ridge height's pretty good. We've got decent quality of bone. We've got decent constriction. There's really not anything that I have to complain about. So this case here would be a case that would be something that would be a great case for more of a beginner surgeon, somebody doing implants, doing the prosthetics, that kind of stuff, where you're doing more advanced dentistry to try to figure out the solution here. Obviously, they don't have a bridge option. The one little tricky thing here is that there's a root canal treated canine right at the front end of these extracted teeth. And it doesn't have a crown either. So that's kind of one of those case-by-case scenarios. You have to decide on what are you going to do about putting in a crown, making that weaker, or leaving it the way it is. But certainly she doesn't have anything up here yet to chew again, so that'll last a long time. So let's look closer at what this bone actually looks like here. So when we look at that as a recent extraction site, if you look at the CT view, here's what it looks like. There's not a whole lot. I didn't do the extractions, but I'm really happy that this doctor did not break away this facial bone. So when I see a case like this and the doctor didn't graft it, I don't think the doctor had that ability, or at the particular clinic that she had these extracted was able to have this grafted in the first place. So what do I do after she's had these teeth extracted for a month, and what is my recommendation? Do we want to fill that up with graft? A lot of dentists would say yes. They would say, let's jump in and do a graft. This is not a graft because I feel that this bone will stay, and when or if this bone does resorb away a little bit, it might just be a small tip because there's fairly hard bone right away on both sides. You got to remember that there's this little area that is the little bit of the bone that's right down the middle of that site that's going to become the little defective area. And I think the bone is pretty hard already, that maybe if you didn't do a graft, you'll probably get a shelf like this. If you did do a graft, you might preserve it there, or you might get it to there. So that doesn't feel like there's a whole lot to worry about, or that I need to feel like I can't be successful because this patient has so much other work to do. Look at that's already higher here if you don't even do it. So let's say, so you're probably not going to get a great benefit from having a graft. So I try to side on the patient's side to look at it and go, well, you know, you're already here, it's already healing over, probably don't want to delay things anymore. You're going to get bone in the first bone healing event that's kind of growing into this area, and it's not going to be detrimental if you didn't do a graft. So I'm okay with that. It's not a cosmetic area. And let's look at the next premolar site here. Very similar situation. The bone, let's see, let me get that. The bone looks pretty good. See, you have a much wider facial wall here, and that allows you to not have to support the bone growth through here, because that bone is actually going to allow the bone to grow across the socket site and fill up. The other thing is that you have right here, from top to the nerve, you have 17 millimeters. So your nerve position, your IA nerve position, is also a green. So you've got quite a bit of room. You're only going to put 11.5 by 4 or something. You just got to let it heal in. The thing about a graft that I like is that it does help hold the space. Even if you go in 3.5, 4 months after the first bone healing event, I feel like the graft is still closing up the void. I don't feel like there's as much of a void there. So it's hard to say. I would say save the expense for the patient. You don't need a graft here. Now let's look at the molar area here. This is much wider and much broader and is missing a lot more bone from that extraction. There's no interceptal bone. I don't know where the starting point is, but once again, you have a very full facial wall. You're not going to gain on height here. You're got a nice distance. You're not going to put an 11.5 in here, but you would do a 10 millimeter or something, and you would probably do a 5. If you even have a 6, that would work out really, really well. So this case is really pretty straightforward when you really look at it. My concerns always go into these crowns and some of the restorative elements. So the other aspect of this case would be, do you only put an implant in here and here? And I would say, yes, that's totally fine. Do a wider, shorter implant here, do the 4.5, 4.2 there. You can do a 3-unit bridge. As this patient gets older, the patient will, if they lose the rest of their teeth here, they have 2 implants in the right position to do a 4-locator overdenture on that case. So stay tuned with us. We're going to be moving on to the upper case very soon, and just watch us. Give us a subscribe on YouTube and like us on Facebook, and we'll be back to broadcast more. Thanks.